Good afternoon, ladies and gentlemen. A warm welcome to all of you to APAC Dialogue on behalf of APAC News Network. We have today a very eminent guest with us. We have with us today Dr. Sushil Kumar Meher, CIO of India's premier medical institution, All India Institute of Medical Sciences, AIIMS, New Delhi. So before we embark on the discussion with Dr. Meher, just briefly a little introduction about APAC News Network. APAC News Network is a knowledge-based media organization headquartered out of Noida with a pan-India presence and presence outside India in several Asian locations. We primarily focus on how technology is deployed in different sectors like government, healthcare, education, BFSI, enterprise IT, startups, SMEs, and the likes. Welcome to today's show, Dr. Meher. And what we would like to primarily discuss, I would classify it under two parts. One, first, we would like to focus on the technology deployment specifically at AIMS, then AIMS technology roadmap, the new emerging technologies that have been deployed here. And the second part we would like to discuss AIMS is sort of the torchbearer for the Indian healthcare segment. So, how are some of the best practices being replicated across Indian healthcare sector, and what role AIMS, mentoring kind of role, if I may say, is playing? So my first question today to you, Dr. Meher, would be if you can take us very specifically through the major technology deployments that have taken place at AIMS. Over to you, Dr. Meher. Thank you.
Yeah, before that, deploying the technology, you should have the infrastructure what you have. We have a full phase of infrastructure. We have our own data center, we have our own network, we have our own storage, and all are in our premises. And we have built up a enterprise architecture where we have defined the business layer, the infrastructure layer, then process layer, and technology layers. Each things what we have done it, you have made a strategic objectives what we have. Then we have evaluate the business capabilities what you have. Another the what are the business process, because in the healthcare segment, business process is a very complicated and a very adjusted. So to define a process, that is a very difficult task for a um, person who is doing the business process reengineering. Then what are the architecture we for the functional architecture, and simultaneously what are the functional capability what you have to integrate. The third thing is that we have the application and the data which is in the form of informations which has been done in a another logical data architectures we have made it. Then another one is the what are the softwares which can be used to manage all the applications within the enterprise network. That has to be come up, which is also being used with different applications where you are managing the whole infrastructures. Then integration part, we have our converge and hyper converge based architecture, how it will be used in our storage, cloud, and servers. Then we have another architecture we have made of how the data has to be populated in different locations for storing, retrieving, and archiving. Because AIMS is not only the data in the sense of imaging each play major roles, and which is the high density of image. We need a lot of storage for it. And today's days, what we are planning within 5 years, so we need a whole data. It will be around 5 petabytes. So it is a huge data. It will be there. Another one is that all the infrastructure is supposed to be connected proper in a network. So now I'm coming to the what kind of server infrastructure we have. We have hyperconvergence, which is being uh, translated to the Docker technology, containers and Docker technology, but yet we have not done it. Right now, we are in the hyperconvergence, and where the data is being stored in one place and it will be replicated to other locations for the high build in HA forms. And in the means hyperconvergence, what you have done it, uh, uh, we have our send storage, mesh storage, and the servers which is connected to our high performance networking, which is 100 gigabits backbone, which is working in different locations. And this network has been three layer. One is the main backbone is 100 gig. The middle level from building to building it is 100 gig. From floor to floor it is 40 gig. And floor to the end users it is 10 gig. And from 10 gigs it will be to the last point of ending it is 1 gig each node supposed to be get. So these are the infrastructures which has been built up within the AIIMS. Still, we are unable to convert the old infrastructure also. This is a new infrastructure we have placed in some locations. Some old locations, we are in the process to make it same infrastructures, same bandwidth, same speed of network to access the to access to our data access to our data centers. Okay, we have multiple type of infrastructures. We have our own infrastructures which has the hyperconvergence. Simultaneously, we have there for high availability. We are in the cloud also. We have Megraj cloud of the NIC, where we are putting our medical records, not the imaging to that part. We have our own public private clouds within the campus. So we have hybrid clouds within this. We have a small data center, edge data centers in different location of the AIIMS. AIIMS has the means not a one campus in one locations. It has different campus. We have in Ghaziabad. We have in Ballabgarh, that is in the Haryana. We have NCI, which is been in Jhajjar, that is also in Haryana. So all are connected, and the data is replicating to our own edge data centers within the our private clouds. So these are the infrastructure right now we have to manage all these things. We have some softwares we are looking into it. For network manageability we have ClearPass, which is being deployed. So we are looking into the what are the means loads in the networks, how to manage the networks. That is we are looking into it. We have installed Javix software. It is free of cost, open source. How to you see that what is the load it is coming to the different servers, so that if the load is coming very high, then how to manage, how to how to make the things load balancing in different servers so that the performance will go up. So this kind of infrastructure right now we have in the AIIMS to deliver the IT services to the users. Our user is not within the campus. Our user is the patients, those who are he may be in different states, to assess their medical records remotely, which they have got treatment in AIIMS. So these are the basic short summary of our infrastructure which has been placed in AIIMS. Yeah, over to you.
Thank you, sir. So, from this infrastructure point of view, before I come to more specific technology deployments, I have two questions. One, you mentioned about some of the other campuses. My question is, many of these, that you have separate data centers in some of the campuses, but overall, when you are talking about the storage infrastructure, the SAN or NAS,
Mhm.
the data centers, the network infrastructure. So, infrastructure or the server you talked about. So, be it compute, network, or the software part of this infrastructure, do all the AIIMS across India share this common infrastructure, or is there a separate architecture for each of them? So I'm talking about those in other locations, the Rishikesh AIIMS, say, or like those. So one is that part. Second is what you mentioned, to maintain an enterprise architecture requires an IT team with all these necessary skill sets and a significantly large IT team. And since many of these things, as you mentioned, are being done in house. So, my question is, while obviously AIM's core competencies in healthcare, so for this technology team, how do you manage that? Is it through third parties, or do you have a significant in house team who does all the things?
Okay. The first question is that our infrastructures for the other aims. Okay. Uh, First, you have to understand that AIMS New Delhi is one of the independent institutions. They are not any relations with other AIMS. All are one independent entity. Okay. Sharing the infrastructures, it is not possible because we do not have any agreement or MOU with them. In future, it might be, but one thing you have to understand, two things are there. One thing is that infrastructure, another one is the data sharing. Okay, for data sharing it is not possible because we have to use the same applications with same standards, where the means record can be interoperable, which is not been done yet, because the government of India has already been defined their standards to everybody has to follow, not only the aims, all the government and private institutions, they have to follow it. That is ABDM, Aishwan Bharat Digital Mission. So majority of the organizations yet they have not followed that one. If it is been followed, then the record can be exchanged, or the record can be accessible by the patients, by the doctors, on the concern of the patients to access the medical records. So right now it is in the process. It will long way to go. When you are talking about the infrastructure, what we have, how to manage this one. In AIMS, what we have defined, we have three teams are there. One team is which look after the ERP of the back office. Another team which working on the healthcare, all the services and activities. Another team is total infrastructure. Total infrastructure means that team will be involved in the networking, they will involved in the servers, data centers, clouds, and networks. So in that cases, definitely our team is there. Our teams always they upgrade their knowledge, but the manpower which is required, it is not possible to maintain by the own staffs. So we have a teams which has been outsourced for the networking, which we have a team which is outsourced for the peoples, those who for the servers infrastructures. We have a team which is outsourced for the storage management. So all these things it has been outsourced, but they will have to work with their team leader, which is the AIMS employees, those who are in that projects to working on it. Second thing is that the outsourced persons, they are the people, they can help us out. What will direct them? That okay. Let's take one example I'm giving to you. I have already told about the age data centers. Okay, different aims is not it is institutions, but for the working smoothly, we have an independent entity, and they have the lot of powers just like AIIMS. So we call them, it is just centers. All the centers are their independence. They can take independent decisions. They have the independent budgets. They have a independent administrations. So what they do it, let's take radiological imaging. We have a cardiac neurocenters. They generate all the imagings. They put it in their own data centers. That is edge data center. Let's take radiology departments. They scan the patients. Their imaging will be stored in locally in their data centers. NCI they have their own PAC systems and radiology systems. They scan it. They put their own. But it has been configured in such a way that after scanning, when it will come to their storage, automatically their image will push to the central storage systems, so that it will be easy to distribute all the images to different locations. So that's why we need a huge infrastructure. We have huge infrastructure. We need a huge manpower to maintain in different locations. So that's why the manpower which they are in the AIIMS, they work as a manager or administrator who can supervise where the work is going smoothly or not, whether the policy has been implemented rightly or not. Just like we have an infrastructure of Wi-Fi, how Wi-Fi will be secured, how network will be secured, because network security and application security and data center security, that has to be managed by the one person. So in that cases, they have to see that what security has to be deployed. Then they will instruct to the outsourced team to do this. So this is the way we functions in AIMS.
Okay. Thanks a lot. Now, coming to specifically, especially some of the newer technologies. Let's say first, let's take IoT. Now, AIMS will have a lot of medical technologies, instruments, equipment, which are the OT part of the operational technology, and that has to marry with the IT part. So, how AIMS is looking at IoT deployment, that is one area. Then you talked about so much data and the patient records, how effectively using AI to and analytics to leverage meaningful insights from those patient data. Then even more advanced, how things like robotics can be used in surgery or in some cases certain detection also. So overall, if you can give us a picture of how AIMS is using these newer technologies and how that can be a role model for other hospitals across the country.
Okay. You have asked me three questions. One is the IoT. Okay. First, you come to the IoT. Generally, IoT is a common nomenclature, but in the healthcare, we say it is IOMT, Internet of Medical Things. Okay. We have doing a lot of IoT activities. One example I am giving to you: measure machine, laboratory machines, or IC equipments, or ventilators, or patient display systems, all are integrated with IOMT device. Uh, let's take one lab equipments. Measure of the lab equipments right now, those who are purchasing it has the own microprocessor based processing and storage devices there. Whatever test will be done, it will be stored in locally, and they can be pushed to our servers where the medical records is stored, and it will be stored there. But for this process, laboratory equipments, they have their different standards and codes, and our server is a different standards and codes, but they have to talk each other. So that's why earlier what it was there in traditional systems, we are putting one servers in between, and from the machines laboratory machine to the that servers. From that servers again it's connected to our network. Then from the network it will come to our servers. If this local servers for the interface has gone down, then the connectivity has been lost. And the local servers always it is very difficult to manage. So that's why we have put a one IOMT device which is been compatible with FIRE, the information exchange standards FIRE right now. This is the latest information exchange tools which is being used here. And this IOMT is just like a one mobile size. Okay, and with two cables has to be connected, and automatically the data will transfer from uh, patient records to the laboratory. One example I am giving to you. Let's take today or yesterday the doctor's order for the some blood test, and patient has given the sample, and barcode has been generated. It is pasted in the sample. So how the automation is there? I'm talking about it. When we'll collect the sample with barcodes, put the pneumatic tubes. Okay, automatically that sample will reach to the that lab where the test has to be performed. From there, again it will come to a tray, and that tray it will put it in the pre-analytic and post-analytics the labs. And we talk two labs, similar kind of things are there. One is uh, um, automated lab, another is the robotic labs. So when the sample will go, automatically the samples will be retrieved by the robotic hands. They'll select this samples is meant for this machines. They will send to the that machine for the test. This is the one process. It is pre-analytic and post-analytic. It is been already been used, and uh, this type of laboratory systems first time in the Asia in AIIMS it has been installed, and right now it is hardly one years back. One lab is there, another lab is around 2 years back. It has been installed. In traditional laboratory equipments, you have to again make an interface, and we are using the IOMT. In that cases, when you place the order by the when the doctor has placed the order, sample has been collected. When sample will reach to the machines, when he will read the machines the barcode, he'll send a request to the server that this is the request has come, what test has to be performed. Then again servers will send a message to the equipment, these are the tests for this sample. Then the machine will test that test, then collect the result, again push the information to the medical records, electronic medical records of that patient. So these are the two-way bidirectional connectivity. It has been done through the IOMT, and it is automatically transfer the informations from laboratory equipment to your EMR medical records. This is the one thing is there. Another things, one is in the OT, another one is in the ICUs. In the ICUs, we have the ventilators. We have to take the informations that what is the ECG, what is the EEG, what is the temperatures, what is the BPs, all the informations we can online record to the patient records, so that in futures you can analyze where the patient has faced the problems and what kind of treatment has been done, and where there is scope of improvement. In that cases, again we have used the IOMT device in the patient bed near to this, and already I have told you it is just like a mobile device size. It is not a big one to put it there. Just put the two cables and configure it automatically whatever you are seeing in the screen, all the data, it will be transferred to the patient records. And this is the one things we have done it. Simultaneously in OT also, same way we have used this, the OT devices, it is connected. Whatever data is generating, again, it will be captured and transferred to the patient records. So in futures, if they want to analyze, they can analyze it. And if you find some improvements, they can improve it. So these are the totally automated and very, very less manual systems right now, which is in place in many places in AIIMS. Over to you. This is IOMT. Another one is you have told me about that the technology what you are using it. Generally, we have a uniform electronic records, okay, and that is called EMR records, where it's one single registration number which has been generated at the time of admission. It is called UHID. Right now, we are planning to connect to the National Health ID, and already been government of India has placed that each and every citizen of AIIMS, or each and every citizen of the country, they supposed to make their own health ID. So if they will go any of the hospitals, they can put their unique health ID there, so that uniformly the health records information can be collected, and they can push to a single medical records for the one citizens. So this is in the process. Again, it is not been done many places. See what it happens. I'm talking about it. You are showing in the in AIIMS, but before that you are showing in some other hospitals. They have their your records. In AIIMS, you have your another records. You have done some tests in some private labs, another some records are generated. Right now, ABDM, Aishwan Bharat Digital Missions, they have already created a standards. You have to follow this. Each and every one has to follow it. Each and every one service provider has to follow it. Whether a doctor who is seeing in his own dispensary, they have to also follow. Whether AIIMS, any AIIMS of the country, they have to follow it. Any private organizations also, those who are giving health services, they have to follow it. Even the peoples who are giving the services uh, for the any nursing services, or your any means other kind of services, just like your any therapy services. Even the government is saying that if you have a some healthcare services, or you have a some kind of lifestyle services, in that cases also they have to be integrated here, so that the owner of patient record, each patients, the patients have the one ID, that is the health ID. From that health ID, he can access all the records in different locations, make a single records, so that when you go any doctor, he can say this is my health records. And if he wants that this record has to be shared with that doctors through OPDs, yes, so through the OTP, he can transfer his record to his own treating doctors. In that cases, doctor has the huge information about his patient, and he can take a right kind of decisions to give the treatments. This is the process, and very soon we'll find everything's in one place. Over to you.
Okay, thank you. Two questions emerge out of here. This Uni Health record, which you are talking about, one, how do you ensure, since this involves a patient record for a patient from AIIMS, from private hospitals, from private diagnostic centers, and ultimately assessing all those records. So, how would you ensure the privacy and security part of it? That is one part of the question. And second part of the question is, you mentioned earlier, healthcare system, the users are the patients. The other very critical, I mean, say, component of the healthcare ecosystem, are the caregivers, the doctors and the nurses. How do you ensure that the doctors and nurses are also synchronized with this IT deployment, so that the care they give, that is also gets optimized?
Yeah, it's a very good question. Yeah. First, you have to understand that any service provider who is giving it, they have to register. If AIMS is a service provider organization, they have to be registered, and they will get another ID. AIMS will get a single ID. Again, in AIMS, the doctor is treating, nurses is treating, physiotherapist is treating. So all the service provider, even doctors have their own ID. So how will get this ID? Again, the questions. All the doctors they have registered themselves in MCI, so that ID can be used. In nursing also, those practitioner nurses they have their own ID from their own nursing society, that can be used. Similarly, the physiotherapist they have their own ID, they are also their one associations, that ID can be used. So that if you are getting different treatment in different hospitals, in different doctors, all the IDs it is attached in each episode of your treatment. So how transparency you see it? This treatment I have got from this doctor, from these locations, or these institutions. If something has anything malpractice has been done with you, it is very easy to catch it. You know it in the healthcare services. Many things it is happening which is not required, and they are generating lot of funds funds. So that's why this kind of things it can be stopped in future. Next question is that how these records it will be generated and how it will be there. Government is planning to make another uh, HIE, Health Information Exchange. Okay, so that through this services one can exchange the records, and it will come to a single medical records, it will be there. Another question is what you have asked, that this records how it will be confidentiality and privacy. Okay, already I have told you that today's date what it is, when you will showing your doctors, by default you are giving consent that I'm open to my health record to you, whether it's a physical or whether it's electronic. So it is not required to sign any agreement. But when it is electronic forms, in that cases, when you will exchange it, the exchange of the government, the HIE, it will register that you have exchanged these records based on this consent to this person. So that is their log file. It is to be maintained by the your health authority. That is ABDM's authority. This is the way to do it. You are talking security and confidentiality. There are two things again it is lacking. Personal data protection bill, yet it has not been passed from our parliament. So this is a personal records. I'm talking about health record is as such, and already I've told you that owner of health record is itself patient. Okay, if the patient is unconscious, how? Without his consent is not possible. In that cases, the next closer relative to be part of this, and they have to allow to access these records. Let's take if the patient is conscious and his father or mother or brother or wife, if you want to access, is it allowed or not? No, nobody can access to it except the itself patients. If the wife is saying, I want my husband's medical records, it cannot be shared as per the guideline, today's guideline. This is the confidential. But the main issue is that if the personal record protection bill will be come up, then we'll get a new directions in this area, how to share the records to different people. Another questions another things I want to answer it. All the records is to be stored there, and we need some analytical work. Otherwise, that is why the use of these digital records. If the government is want or any agency is want, the record can be shared without any name, without any registration number, without any address. It can be shared with hash, so that on identified records it will be available, so that different agency they can assess it, they can do it. Just one example I'm giving to you. If the government will know that this kind of disease in this location is highest, particular this period of time, so in that cases, that kind of infrastructure, manpower will be deployed so that they can fight for it. Otherwise, it will be again the things which is going on as it is nowadays. So these are the one of the plus points. Second thing is that government can do right kind of budget to spend, where to spend, how much budget to manage the all the disease and health services. That is the
Thank you. Another important aspect I would like you to touch upon is, and especially this is about the remote monitoring of patient, remote diagnosis, and remote treatment through telehealth. We know just before the pandemic, the telemedicine guidelines also came into place, and this telehealth thing was for obvious reasons during the pandemic became very predominant. Now it is again reducing. So, how do you foresee the future of telehealth, and how do you see the technology evolving in this domain?
okay. Since 1999, I am already been in this area of telehealth. Okay, just giving a background. So in 1999, the four centers government had been given that as a pilot project that start telehealth through ISRO satellites, and the infrastructure was so expensive that it is not possible to deploy other locations. And we have started with AIIMS New Delhi, PGI Chandigarh, Sanjay Gandhi Lucknow, and Jitman. So all the four peoples there on the boards, and they have started to give the consultations. At that time, the consult because very it's a very limited access. That's why uh, when you are talking to the different locations, it was doctor to doctors, because because the technology has not reached to the patient level, and you have to come to the telemedicine centers, and there you have to start consultations. So in these cases, many hospitals they discuss different kind of critical disease, how treatment has to be done, so that one type of CME, continuous medical education program, has started. First, this way. Second things what I started, some critical patients, they need a second opinion for this patient. In that cases, they make a call, they and discuss one senior doctor from one hospital to other hospitals, and take a decision that what to do for these patients. It is 1999 to 2004 when the internet has penetrated. Then people have started other type of teleconsultations. And in these teleconsultations, what it happens, I'm talking about it. I have done a good survey for this, and scientific survey I have done it, that peoples do not have the confidence on technology. Many patients they have told me that without seeing a doctor, how I can get a treatment. So that is not possible, because when I'll inform the doctors, he has to put his stethoscope in my body. He had to put his hands in my nerve, and he can see my eyes, he might see my tongues and all these things, and they can do some clinical evaluations. Then he'll thought for what kind of test has to be performed, what kind of treatment has to be performed. In 2 years back, before pandemic, one conference. This is a very big conference in the USA. And it is a radiological conference. About to be more than 70,000 delegates they attend physically in that event. It is a huge conference. In that case, in planetary talks, one uh, speaker has spoken. Still, I believe that when if I will not touch the patients, I'll not be confident to give a consultation to the patients. This mentality still it is there within the doctors. For the patient sides, what we have observed at the time, those who have the money, who can travel from out location to the doctor's place, they do not like to do any teleconsultations. Those who are poor people do not have access to the doctors, and if they are getting an opportunity, they are ready to do it. But already I have told you, doctor to doctor consultation, it is another issues that if you have a good relationship with doctor to doctors, they take consultations. Or if the doctor is a student, another is a teacher, in that cases they like to take a consultation. Otherwise, they have a own ego itself in the with them. They do not like to take a consultation to the senior doctor from the other hospitals. This culture still it is there, but right now technology is unplaced. People they can connect to the doctors, they can take appointments to the doctors, do the some teleconsultations. It has started largely after pandemic when they found that they can't move to a doctor's place. So it is a better option to choose these options. Earlier, the hesitation was from the doctors. They say, right now we are seeing the patient physically, and the load is so high, they do not have the time to give the time for the teleconsultations. So it is an extra burden for them, and they will not get any extra incentive to give the teleconsultation for it. So many doctors they do not like to participate in it. Right now, when the pandemic has started, doctors have also their mindset has been changed. No, I can give a consultations remotely because the pandemic is there and the physical contact it is not been allowed. So in that cases, the culture little bit has been changed, and people have started accepting the technology.
But
That's
there is
why,
a medical legal challenge also, sir,
yeah,
to
yeah, yeah, I
this.
will come to that. I will come to that. Right now, what it is I'm talking. Right now, the technology has also in the last 2 years it has come up that you have a electronic record in your computers. If the electronic record is not there, if the patient is remotely, whatever test is been done, whether physical record is there, he's scanning from the mobile, uploading in the patient records, and take a appointments, do the consultations, do the consultations. In that cases, doctors is also easy to see the what are the test has been performed, what are the reports it is there, what is the past history of the patients, all these things they know it, and they can do the consultations. That's why the one software which is developed by CDAC is e-Sanjeevani. It was very popular. Largely it is people have been used by the government organizations and well tested, well effective. Millions of teleconsultation has been done last 2 years. This is one of the positive sides. In AIIMS, we have developed a one doctor dashboard. Any patient has to take the treatments during the pandemic, during the lockdown times, or without lockdown times. In the lockdown times, all the patients who are already registered, their medical record is available. Only the teleconsultation who has been given because the record is with us and doctor can see it. He can give the follow-up consultations for it. If the patient is not registered, we are not taking it. But later part, what we have done it when the pandemic is there and lockdown is not there, patient is moving to the hospitals. but still some people do not like to come to the hospital. In that cases, there is two categories are there. There's two categories are there. One category is that you have to choose a appointment. This appointment is whether it's physical or it is virtual. If you choose physical, we have some slots for the doctors. If you are choose for the physical, then another slots is there. So, so what it happens when doctor will be seated in the OPD, he'll call the virtual one, then he'll call for the physical one. And in the dashboard, his medical record is coming and the video consultation is going on. In this way, we have done some of the department consultations. Uh, right now, you come to the what is the legal issue, what is the ethical issues in the hospitals, particularly in India. Ethical is play a major role. See, one example I mean, if the patient is sick, I do not have the whole medical records. Just you have to what you are seeing it. Somebody is saying that he's unconscious, but he has a fever, he has some vomiting, he has some other symptoms. He need a consultation. If doctor is seated there, whether he'll give a treatment or not, first of all, or he will deny it. No, I do not have any information. I can't do it anything. This is the one thing. See, with the ethical issues, if the wrong treatment has been done, then he has gone to the legal issues. In that cases, what to do? Still, it is a not clear for us. That's why many doctors they are hesitant to do it. But some of the doctors they are coming up as a doctors. We have the responsibility to give a treatment. This is the one thing, one part of it. Another part is that we are talking about the legal issues. Legal issue is not clearly defined because when the pandemic has come, government has thought the document is available but it's not ready for use. So immediately they have plan out to roll out the things. What it is, let's be roll out. Then later part we can amendment it to do it. But still lot of lacunas are there. Lot of doctor community they are hesitant to do the teleconsultations. But many people what they are doing it during the teleconsultations they are doing the all the recording services. They records all the information what they've been giving it. They are taking the consent from the patients that this is the information it is true, and they are ready to get the treatments. Then they give the consultations. So this is the ones pro and cons are there till date. But again, government definitely they are looking through it that what is the improvement is required from the these guidelines.
Okay, okay, sir. Thanks. That was very lucid. Now, another aspect I would like to touch upon two domains which are very, I would say, integrally synchronized with healthcare. One is insurance, other is pharmaceutical. And if we look at technology wise, pharmaceutical and health insurance are very technology savvy, and advanced technology has been deployed. So, how do you see from the technology perspective, the synchronization between healthcare, insurance, and pharmaceuticals?
Uh, from the beginning, I am talking about ABDM, Ayushman Bharat Digital Mission. This is a one of the good initiative by government of India that they want to bring the um, technology so that they can be reimbursed. Okay, Ayushman Bharat, the one to the 5 lakhs rupees for the each family they can get if they are if their income is this much of group. So in that cases, government is facing the problems that in the family how many people are there, the family is within one place or different places, whether it is joint family. So a lot of things are there. When we are talking about the health ID, then you have a unique ID. See, and whatever treatment he has done already will be recorded. If you take an insurance, in that cases, the insurance person can see it that he is this kind of patients, so that the insurance persons he can he has the confidence that okay, I have to give you insurance, but the premium will be this because you have a past this type of disease record. This is the one of the plus point it will come up. Second thing is that reimbursement of this one. Right now, I'll talk about the government. That's why government is in the plan to do it. That single medical records it will be interfaced with the health information exchange, so that record will move and when will registered. There is a lot of informations are there. You are from the which family, you will get a family ID. Lot of things are there, so that if you have more than 5 lakhs, then you have to pay for it. If you are the less than 5 lakhs, any person of your family they can get the benefits anywhere, any part of the India. This is the one of the insurance reimbursement is there. Same things it will come to the private also, because already I have told you that all the hospitals they will be integrated with ABDM. It is compulsory and they have to do it. They cannot back out of this. When it will be integrated again, the insurance company what they will do it, they will go, because they are also service provider and they have their own ID. They will do the logins. They can see the patient's ID, the health ID, and what other treatment has been done, what is he claiming it, from which service provider it has given it, everything is available. So this kind of things it is coming up. It is not yet it is in place. Right now, what is going on? I'm talking about during the COVID time. Many people they have their insurance. Some people have died. Some people have admitted in the hospitals. They want reimbursement, but still some records are already been stored somewhere. Our COVID records, the COVID positive records or negative records, it is already been stored in the ICMR servers. So many queries, or most of the queries, those who are claiming for the insurance, they validate in the ICMRs and they process their claims. So these sort of things, it is already been people are doing it. But in future plan, this is the only way to way out, because everybody will come in single platforms for the treatment, reimbursement, facilities, all these things it will come up. The another plus point which I'm saying, we have not asked me. Let's take one doctor is available at your doorstep and you do not know, because your whole day you are busy in the evening, you will come you will at home, but some specialist doctor nearby and they are ready to give the treatments, and in the evening you have some issues. If you are registered in the ABDM, you have own health records, you can see that who are the doctors is available nearby. Just like Uber and Ola. If you need a car, go to the apps, see it, the cars is available nearby or not, and how much time it will take to reach. So in these cases, all the stakeholders it will come in a single platforms. You there is a one apps the government will give to all the citizens. The My Health apps. Here you can assess your own records and you can assess the who are the service provider is available. Let's take your parents is not well. They need a nursing services. You want to find a nurse who can nearby for 3 hours, so that so that the nurses who is registered there, it will populate it in the screen and you can choose it. So healthcare it will come to a consumerizations. Okay, so that if nurses is working for 10 hours in his workplace, rest of the hours he can use in this method, so he's getting extra employment, and the patients or the citizens they can empower to choose any one of the services if they want. So these are the things interface it is going to be done very soon. So when we are talking about insurance reimbursement, in that cases, right now it is almost a manual systems, and though there is no proper transparency is available. But when will ABDM is placed, you will get a transparent, quick reimbursement without any paperwork. It will be online electronic forms.
Okay. So the last question I would like to ask is in terms of one, what is AIMS technology roadmap, and specifically, which are the technology initiatives coming, which you would like to highlight?
See, AIIMS, right now, AIIMS is getting around 12,000 patients a day, more than 700 admissions in a day, around 600 patients we are getting in the casualty, around 200 plus patients we are getting from the trauma care. So this is the loads we have. Another things for the giving the service, we have 12,000 permanent employees. Another, you can 6 to 7,000 we are contractual employees. So we need a technology, all the services which can be done properly. Definitely, we are looking towards, we are to have a smart hospital. Okay. Over the years, in many events, I have already told you that since the paper tab, we are using the computers in AIMS. Means you can talk about 1960s, we are also using the computers. And till date, we are using the supercomputers. So technology in AIMS is not a new thing. Most of the people's well versed for the technology, IT technology. They understand good IT knowledge, but thing is that how to integrate everything. And for this, to make a smart hospital, let's take one example I am giving to you. If the patient, when he take an appointment, he has to take what kind of service, whether he need a parking for his own car, whether he needs a stretcher, or whether he needs a wheelchair. So all these things he can book early so that he will not face any problems. Second thing is that when he will take appointments, the date and time is fixed for a particular doctor. And if you need a wheelchair, wheelchair will be available. Parking is available. When you transport from the parking to the particular building, car is available to you. The sharing car is available to you. So this is a continuous flow of patient from different locations so that it cannot be overcrowded, because when the 12,000 patient is coming, definitely another 12,000 each associated with him. Sometimes some people come with two people or three people, so around you can see 40,000 peoples for this, they are in the campus. So this can be reduced if this facility is available. Then they'll say that one person is sufficient. I don't want, because my wheelchair is available, my vehicle is available where I can get there and it will reach to that place, and all the buildings are disabled friendly. So these sort of things, it is means we are planning to do it. Second thing is that we want to be a smart hospital. Why I'm saying it? Let's say somewhere traffic is there and the person who is deployed there for the security service is not available. Immediately we can have this informations to act very fast. Okay, somewhere some digging has been done and it has not been filled up and lot of traffic is going that side again. So that will be integrated our hospital management and administration so that they can act very fast, or the agency they can get the information very fast. Third thing is that I have already told you that we want to be a smart hospital means we need a more automations, more fast. What we are planning it, if the patient is coming in the morning, when doctor will see it, he'll write some test, some scanning. In that case, same day he has to complete it and he has to go back. Same day he has to complete it, same day he has to report it, and in the evening he has to show to the doctor, then go back. Today, that's what it is happening. He has to take appointments. Again, he has to show the doctor. He has to write some test. Some test is it requires 15 days for appointment. Some test it is 3 days. Some test it is 7 days. So what they do something from outside, something from AIIMS. Right now, the problem is that some records are from outside, some records are in our servers. We do not have a complete record of that. If the automation will be done, everything it will be in one place, and all the records, all the information of the patient, it is available in one place. This is the things. For this, what you are doing it, you can ask me what you are doing it. Already, I have told you that you are already placed the IOMT to connect different machines. Connect connect different means instruments uh, which is being connected with the patients. Even if the patient is coming, we want to take a height, we want to take a temperature, we want to take the BPs, all are will be in the OPD levels. When they will do all the tests at that times, through machines it will transfer to the medical records. When we will reach to the doctors, okay, his BP is this much, his temperature is this much, his the height is this much, his weight is this much. All these things is available. The basic information is available. So it will take less time to the doctor to react. And already I have told you that today's days it is automation, but not fully automated. That's why around 35 to 40% of the doctor's time searching for their old records or talking to the patients, which is already been done and is available in the records, available in the screen. So it is not required to say. Just you have to basic information, which is we can ask to the doctors, so that doctor have saved the times, and the requirements of manpower will go down also. This is the things we want to do the automations. That's why we have used many things, just like. Uh, we have used AI tools just like bots as a trial purpose to screening the patients. Many times what it happens, I have a stomach pain. To whom do I have to show it? Whether it's a gastroenterology or whether we have to show to a medicine. If the patient is required to be meet a physician, it is not required to gastroenterology, because gastroenterology is a very highly specialized one, so that we don't want to kill their time. So in the medicine levels, that can be do. Sometimes what it happens, you have a pain in your knee, whether he has to go to the orthopedics, whether he has to go to a PMR, whether he has to go to a rheumatology. So in these cases, many people's they go wrong places. Again, they have to come to the right places. So this is the waste of time, waste of resources, and the patient suffers. So that's why we are planning to do all the automations, whatever it is available today, and uh, which is to be implemented. Another things is that is the AI. We want to have a many cases, many development is going on in Indian standard methods, just like your prediction of cancer of a patients, prediction of the cancers, how he'll get a good quality of life after the cancer. Then we can formulate how we can predict that what kind of treatment he can respond better than any other medicines. Lot of things. This project, it is again it is with me, which we are I'm working for the Ministry of IT, who has provided this research work to me, which we are working on it, and we are in the final stage to make a model which can be used by other hospitals. With two models we are using it. One is the light model, another is the heavy model. Light model, it can be used in your mobiles. Another is the heavy model, it can be used in your workstations to get the predictions that if you have a breast cancer, and what is the quality of life it will come up, what is the treatment plan it has to come up. So with this kind of predictions we can do it very faster and right way. So right now it is the initial stage. Why I'm saying why it is initial stage, and if somebody can ask me, in the US or in any developing countries, they are doing a lot of AI activities and all these things. They are doing, there is not a issues. Issue is that my record is not standardized. People do not follow any standards. They are using their own nomenclatures for the same disease. In that cases, the computer can't recognize it. Right now, government is forcing to use SNOMED city standards for the clinical records, which is been in the process. And this SNOMED city licensing is free to all the service provider in the country. They can use it. So this is the one things which is been AI is a bottlenecks for us, because we do not have a sufficient meaningful standardized records which can be analyzed by the AI models. Thank
Okay, sir. Thanks a lot for taking your time. That was very uh, elucidating and very detailed discussion. I'm sure all people who are watching this live and will watch it on YouTube will be benefited. Uh, Thanks for this very informative
you.
discussion. Wishing you a good day. Thank you, sir.
Thank you. Thank you.